Hello, I'm Tobias Welty. I'm the head of the Department of Respiratory Medicine and Infectious Diseases at University of Hanover in Germany. I want to present you a case of a lung transplant recipient which develops problems. So the purpose of this case presentation is to provide an example how we should deal with such kind of problems and how we can use such a case report for educational purposes. This is the young lady I talked about, a 30-year-old woman which has been double lung transplanted years ago. Herself was CMV negative at the time of transplantation, and the lung transplant donor was CMV positive. CMV reactivation occurred 2 months after transplantation and was treated according to the guidelines. Some times ago, Aspergillus fumigatus was found in a surveillance BAL sample, and the normally given itraconazole prophylaxis was changed to voriconazole. Some months later, the female was admitted to hospital with a suspected pneumonia. She reported increasing dyspnea for about 48 hours, and when she was admitted, cytomegaloviremia was confirmed by PCR technology. 12 copies per cell were found. On day 2, she worsened and she was admitted to the ICU because of respiratory failure. This was the medication at admission to the hospital, so it was a triple immunosuppressive therapy. This is a normal immunosuppressive regimen in lung transplant recipients. Normally it has to be high dosed because the lung is the organ which is most likely to be rejected as it has a direct environmental contact. Sulfamethoxazole is a pneumocystis prophylaxis. The other drugs are used to prevent osteoporosis and to treat hypertension. So normally lung transplant recipients are set on valganciclovir as a prophylaxis for CMV, but in this case, where CMV infection has been diagnosed, it was changed to ganciclovir 200 milligrams 2 times a day. Some information about the physical examination: the patient was hypoxemic, slightly febrile, dyspnea at rest was increased with 21 breaths per minute, and auscultation of the lung showed a prolonged experium, rales on both sides in the lower parts of the lung. This is a chest X-ray. Chest X-rays in lung transplant patients are very hard to interpret. In this circumstance, there seems to be an infiltrate in the right lower lobe and a little bit an increase of the lung structure. But to be honest, this could be also a normal finding without any pathophysiological impact in lung transplant recipients. Here are the biochemistry findings, and what is very important, there has been a normal leukocyte count during former investigations. At admission, leukocyte count was normal, but 1 day later it decreased and was under the normal lower range. Looking to the other findings, most important, there was a dramatic decrease in the thrombocyte count. Looking to the other biochemistry findings, nothing is really unnormal, with the exception of a dramatically increased CRP, signs of acute renal failure, and the hypoxemia with a metabolic acidosis in the blood gas analysis. So leukocyte and thrombocyte decrease may be a finding which is very typical for a CMV infection, and the physicians interpret the data at the beginning in this way. Looking to the biochemistry findings, what do you think you would do? Would you consider an antibacterial treatment? And if yes, which? Piptazo monotherapy as a typical empirical treatment for nosocomial infection? Or a combination therapy, for example, a carbapenem and a fluoroquinolone as the broadest antibacterial treatment available? Something else? Do we need to cover fungal infection? Should we continue with the ganciclovir? Or is all what we have at this moment not enough, and do we need more diagnostics? We decided to continue with the ganciclovir because it's quite clear that there's ongoing CMV infection, and we used an empiric antibacterial treatment even there's no convincing evidence for a bacterial infection. Ganciclovir was initiated 80 milligrams IV once daily. It was only once daily because of the renal failure, and in addition an antibacterial treatment, Piptazo, 4.5 grams 3 times a day, was started. Also, nothing was really typical for a bacterial infection or a sepsis. On day 2, the microbiological results come in. Blood cultures remain negative. The airway specimen showed few E. coli, a gram-negative pathogen, and a low number of Aspergillus fumigatus. In the stool specimen, viridans, streptococci, and enterococci were found, which are normal colonizers and has no pathological impact. The CMV DNR PCR was still positive, even there was a reduction from the 12 copies at the beginning to 4 copies now. Looking to the antibiogram of the coli which was detected, it was a highly sensitive E. coli, and the Piptazo medication should be effective. My personal interpretation of the data is that there is still a CMV infection. The coli is more a colonization than an infection pattern, and it's very questionable whether it has to be treated. Aspergillus fumigatus, even in low numbers, would worry me, but this will come back to the scene later on. On day 2, when the microbiological results had come in, the temperature is increasing. Even under the antibacterial and the anti-CMV treatment, CRP remains still high. There is a dramatical increase in procalcitonin, and there is a drop in the leukocyte count to 1.6 per microliters, which is really threatening. The respiratory state also comes down. There are phases of oxygen saturation deterioration under 80% of normal. The treatment was escalated. Caspofungin was chosen to treat the Aspergillus species. To comment on that, echinocandins are not the first-line treatment for Aspergillus infection. First-line treatment would be an azole, for example, voriconazole, or liposomal amphotericin B. However, due to the acute renal failure and the high likelihood of interaction, no azole was chosen, and caspofungin, known as a salvage treatment for Aspergillus infection, was used. Here are the recommendations from the German Society of Hemato-Oncology with regard to fungal infections, and as I pointed out before, voriconazole or liposomal amphotericin B are the first-line treatment. Nevertheless, in terms of contraindications or treatment failure, echinocandins could be used. There are a number of new azoles available. One is posaconazole, which has not been available during the time point the patient was hospital admitted. The approval has come years later. Looking to what we have chosen today as a primary treatment, it could be more likely posaconazole than the echinocandin. The patient deteriorates and due to the respiratory failure, she was intubated and mechanically ventilated, and dialysis was started for the acute renal failure. But there was no improvement of the clinical situation. Therefore, on day 8, a bronchoscopy was performed, which demonstrated these plaques, which are to see here, which are typical fungal plaques in the airway mucosa. This was confirmed by the microbiological workup, which showed high numbers of Aspergillus fumigatus even in the sputum and in the bronchoalveolar lavage. Immediately after bronchoscopy, there was an unexpected raise in creatine kinase, which could not be explained in any way. Therefore, a coronary angiography was performed, demonstrating an open coronary heart vessel system and no signs for myocardial infarction. Nevertheless, the left ventricular function was dramatically decreased. Immediately after the coronary angiography, the patient has a spontaneous asystolia. Despite a prolonged cardiopulmonary resuscitation procedure, she died 1.5 hours later. An autopsy was performed, and during the next slides I will show you heart, liver, and kidney specimen, all showing the same. There was a massive infiltration of the organs by Aspergillus fumigatus. Here the heart. Here a part of the heart muscle showing the typical Aspergillus formations. The liver, massive inflammation and Aspergillus species. And the same in the kidney, where the kidney vessels had been invaded by Aspergillus fumigatus. What would you have done differently? So, would it have been better to choose voriconazole instead of caspofungin? Should we choose an antifungal combination therapy, including both? Is it possible to administer inhaled antifungals, for example, liposomal amphotericin B or voriconazole? Is another form of treatment appropriate in this circumstance? Altogether, this is a very, very severe form of invasive Aspergillus infection. I'm quite sure that even with every other form of antimycotic treatment, there had been no chance for survival for these patients. Nevertheless, an azole had been a better primary choice, and a combination therapy, even not proven in clinical trials, may have increased the probability of survival. Inhaled antifungals may be helpful in local mycotic infection, in tracheobronchial mycosis, but there's no chance to treat invasive aspergillosis with this kind of administration. Back to antifungal combination therapy. There had been published a review recently looking to the data which has been published during the last years. Very surprisingly, there's no positive study published. A number of studies which had been performed had never been published, which make it very likely that they had been negative. So altogether, there's no evidence for combination antifungal therapy, even if it's used in clinical practice very often. And here are a cartoon out of this systemic review. Well, after the patient had been undergoing autopsy, we came back to the family for the medical history. And what came out was the bilateral lung transplantation had been performed in 2009. The first cytomegalomy reactivation was in May 2009. In August 2009, for the first time, Aspergillus had been detected in an airway specimen. Therefore, as it is normal practice in our lung transplant center, the normally given itraconazole had been changed to a voriconazole prophylaxis. Unfortunately, this prophylaxis has been stopped by the general practitioner in January 2010 without informing the lung transplant center. The fatal event had taken place in March 2010. There is a real learning point out of this case report. Aspergillus infection is one of the main killers in lung transplant recipients. If there is Aspergillus colonization without Aspergillus infection, as it was the case here, a long-term voriconazole treatment has to be started, and there's no chance to stop this before finding negative Aspergillus results in lung specimen for several, minimally 3 times in different specimens. The second learning point out of this case report is that it was quite obvious at admission that this is CMV reaction, but CMV reactivation, but there was, in addition, a much more severe disease, invasive aspergillosis, which has been diagnosed not immediately, but only after a prolonged phase of deterioration. I hope you find this case helpful to improve your daily practice. Thank you very much for your attention.